Thank you for joining me today. In this video, we are going to learn for psychiatric medications. We want to talk about psychopharmacology and core principles. So psychopharmacology is aimed to store the dysregulation neurotransmitters symptoms that underlying psychiatric symptoms. Psychiatric medication affect and effective prescribing requires understanding the relationship between the symptom cluster, neurobiological, and medication mechanism, safety monitoring, and must balance efficiency with the side effects, benefit with the side effects. Medical comorbidities and drug interaction, age-related conditions, and patient preference. When you want to prescribe or when you want to study psychopharmacology, you want to think about how the psychopharmacology restores the dysregulation of neurotransmitter systems. You want to talk about the mechanism, clinical presentations. You want to think about the underlying psychiatric symptoms. You want to understand the relationship between the symptom cluster and neurobiological and medication mechanism, safety monitoring, that you want to monitor the medication about their side effects. You want to also consider the benefit, weighing the benefit between the risk. You want to also consider medical comorbidity that the patient have. You want to consider the safety, interaction, drug-to-drug interaction, and you want to also consider age-related considerations and patient preference. Some medication might work one patient that might not work the other patient. So you want to consider those when you are studying this pharmacology and when you are prescribing the medication. Neurotransmitter systems and medication they affect. Serotonin dysregulation. How serotonin dysregulation affects the psychiatric. Serotonin dysregulation affects serotonin pathway originating from the raphe nucleus trigger that leads to mood, that leads to regulation of the mood, anxiety, obsession, thoughts, sleep, appetite, emotion, process. So serotonin dysregulation can affect mood regulation, anxiety management or anxiety, obsession, thoughts, sleep pattern, appetite changes, emotional process. Reduce the serotonin transmission, contribute to depression. So if the serotonin is decreased, is reduced in the transmission, can lead to depression, general anxiety disorder. It leads to panic, can cause PTSD and OCD. So depression, anxiety, panic, PTSD, and OCD are caused by serotonin, because serotonin leads to depression, mood, sadness, excessive worry, rumination, panic symptoms, OCD, and compulsion. When your brain feels the serotonin is less in the brain, it's not available, it causes those symptoms. So less serotonin means depression, anxiety, panic, PTSD, OCDs. Think about that when you see serotonin reduced transmission. It contributes to those diagnoses. The medication is that serotonin that improves serotonin include SSRIs because they block the serotonin reuptake and they increase the serotonin availability in the brain, and they are the first line of treatment for the diagnosis that we talk about. They are first treatment for the diagnosis that we mentioned because they increase the serotonin. They are first line of treatment for major depression disorder, general anxiety, panic disorder, PTSD, OCDs, and their common side effects are, and common adverse effects are, they cause nausea. This medication, SSRIs, they cause nausea, they cause sexual dysfunction, they cause insomnia, they also cause headache. They also have a risk, they can cause also serious risks. Those serious risks that SSRI can lead to include serotonin syndrome, low sodium or SAD. It increases the bleeding risk. It also leads to QT prolongation, especially citalopram can lead to QT prolongation. So those are serious side effects of SSRIs. They are serotonin syndrome, low sodium, increased bleeding, long prolongation of the QT, which is arrhythmia and heart attack. Okay, SNRIs also increases the serotonin and norepinephrine transmission. Use when the depression is a coexist. This medication is used when the depression is a coexist with nerve pain, fibromyalgia, because they increase the serotonin and norepinephrine. They are good for nerve pain. So they are useful for patients who have depression, but they also have a nerve pain like neuropathy, fibromyalgia, chronic pain syndrome. They are good for that. They are useful. Their potential side effects, the side effects of SNRIs include hypertension, sweat, anxiety, and withdrawal symptoms. We are going to move to dopamine dysregulation. What affects dopamine dysregulation have in the psychiatric diagnosis? Dopamine pathway influence reward, motivation, attention, movement, and psychosis. So dopamine affects the reward center, motivation, attention to details or attention, movement, your muscles, and it causes, and it also affects psychosis, can have affected psychosis. So excessive dopamine will produce hallucination, delusion, mania, and agitation. If the patient have those symptoms, they have increased dopamine. If they have any hallucination, if they have any positive of psychosis symptoms, such as hallucination, delusion, mania, and agitation, they have increased dopamine. How about if they have decreased dopamine? Decreased dopamine also produce the opposite of those symptoms. What are the opposite of those symptoms? The decreased dopamine leads to poor motivation. First, they were motivated, not because mania is motivation, they have a lot of motivation. So they will have opposite of the positive. So they will have poor motivation. If you see decreased dopamine, that means decreased activity in the brain, decreased motivation, decreased goals, decreased energy, decreased happiness. Everything will be decreased because it leads to poor motivation, sadness, cognitive is slow, ADH symptoms. It will lead ADH symptoms. So what medication that will help with the serotonin? Second generation antipsychotic medication can improve the positive symptoms because second generation is primarily due to receptor blocker with the serotonin agonist. So it is indicated for schizophrenia, bipolar, psychiatric depression, psychiatric from depression, acute mania. So as a first generation antipsychotic medication will treat the positive symptoms of psychosis. It will improve the dopamine. It will block the dopamine because they had a dopamine increase. These medications will lower the dopamine. Side effects of these medications include neurologic, muscle rigidity. They lead to akinesia, dystonia, parkinemia, deaf dyskinesia. All these are EBS symptoms. They also, those are the second generation antipsychiatric medication side effects. They also lead to weight gain, depression, hyperlipidemia, because they increase the appetite, and they will cause sedation. Those two things, when you are sleeping all the time and eating all the time, you will gain weight. You will develop diabetic. You will develop hyperlipidemia. Also, they cause hypoprolactemia. Prolactin is increased. That is rare, but it's emergency, medical emergency. And that's the endocrine condition. Also, they can cause neuroleptic malignancy syndrome. Neuroleptic malignancy syndrome leads to high fever, leads to rigidity, leads to mental change of a mental status that can lead to coma, and elevate of CK, and aromatic instability. So the treatment of the neuroleptic malignancy syndrome is stop the antipsychiatric medication. You will do ICU support. You will take them to ICU and get support. You will also prescribe dantrolene medication, bromocriptine. So those medications are treated with the neuroleptic malignancy. So stimulants decrease the dopamine also, and norepinephrine release. They treat ADHD, narcolepsy. Their side effect, stimulant medication side effects include appetite suppression, tachycardia, hypertension, insomnia, and abuse potential. GABAamine dysfunction. GABA is a neurotransmitter. So GABA dysregulation leads to GABA is the primary inhibitor of a neurotransmitter. So when the GABA is low, that can lead to anxiety, panic, alcohol withdrawal, and seizure. When the GABA is low, it leads to anxiety, panic, alcohol withdrawal, and seizure. So the treatment is benzodiazepine, lorazepine, clonazepine, diazepam, potential GABA receptors activity. Benzo potential GABA receptor activation. They treat acute anxiety, alcohol withdrawal, catatonic, and seizure. So benzodiazepine, they treat acute because you want to stabilize the patient with panic. So acute anxiety, alcohol withdrawal, catatonia, and seizure. However, they have a risk of dependency, respiratory depression, fall risk, cognitive impairment, delirium in elderly. You want to avoid long-term use when it's possible. Glutamate dysregulation. Glutamate abnormality signal contribute to the treatment-resistant depression. Ketamine and ketamine, ketamine and ketamine are the treatment. They are NMDA receptors agonist, leads to increased glutamate release and enhance syndrome synaptic plasticity. Ketamine and ketamine, they treat depression, treatment-resistant depression. They treat acute suicidal ideation. However, their side effects include rapid antidepressant effect within hour. That is the advantage. Disadvantage and side effects include dissociation, sedation, hypertension, and potassium misusage. Ketamine and ketamine. Acute treatment. If the patient is having an acute, the goal is to stabilize the patient. You want to use antipsychiatric medication. If they are having an acute psychosis, you want to use the benzodiazepine if they have an acute anxiety or withdrawal. If they are manic and they have a bipolar disorder, mania, you want to use the mood stabilization. Maintaining treatment, the goal is to prevent the relapse. And you want to use that SSRIs for the anxiety, that is the long-term use. You want to use lithium for the mood stabilizer. You want to use long-acting injections for the antipsychiatric because you want to use prevention. for the relapse. For severity, if the symptoms are more severe, mild to severe, mild to moderate illness, monotherapy is used if they are mild, if they are having a mild symptoms to moderate of the illness. You want to use one medication. Monotherapy is usually sufficient. For example, SSIR plus psychotherapy. Single mood stabilizer. However, if the symptoms are very severe, you want to combine treatment. You want to combine antidepressant medication with other medications. Mood stabilizer plus antipsychiatric medication. You want to also use ECT for brain stimulation. Evaluation comorbidity. You want to also evaluate the comorbidity of the disease. Some patients may have anxiety and depression. For that reason, you want to use SSRIs or SNRIs. SSRI or SNRI. Some patients may have bipolar depression. You want to use mood stabilizer first. Never prescribe antidepressant medication monotherapy to mood stabilizer as a mood stabilizer because it may cause a mania. If the patient is having a psychosis and substance abuse together, you want to stabilize the psychosis while treating this substance abuse disorder. Serotonin syndrome can cause by SSRI plus MAOI. If you combine these medications, they can cause serotonin syndrome. This medication called linezolid and tramadol, those can cause serotonin syndrome because they increase the serotonin. Mental status changes such as agitation and confusion. Hyperactivity like hypertension, diaphoresis, tachycardia. Those are medical emergencies. Neuromuscular contraction findings such as colonus or hyperphalanxia also are medical emergency. So you want to stop the medication, you want to do supportive care, and you want to hypohaptania. Lithium toxicity can happen because lithium has a short therapeutic range. Symptoms when smile, symptoms include GI upset and tremors. When it's moderate toxicity, it can lead to confusion, ataxia. When it's severe toxicity, lithium toxicity, it leads to seizure and coma and can lead to death. Risk factors include dehydration, NSAID, ICE inhibitor, thiazide, diuretics. All this, they either increase the dehydration, they increase the blood bleeding risk. So you want to stop the lithium and you want to start IV fluid and hemodialysis for if there is a severe lithium toxicity. Somatic therapies. Somatic therapies include ECT. ECT induces control seizures that control the seizure. It will cause seizure, but it's controlled. It induces controlled seizure that enhances monoamine transmission. So you want to, and it increases GABA activity, it stimulates neuroplasticity, and improve dysfunctional neural circuit. So if the treatment is resistant, if the patient having a treatment resistant, ECT can improve that. Indication of a ECT include severe major depression, especially with psychosis, catatonia, refusal to eat, severe suicidal ideation, bipolar depression, catatonia, treatment-resistant illness. Those are the diagnoses that ECT is indicated for. Advantage of a ECT is fast antidepressant treatment availability. It will improve that, and response rate is 70 to 90%. Side effects of ECT include short-term memory impairment, headache, confusion, need for anesthesia. If the patient having a psychiatric depression by suicidal ideation, you want to do the ECT. It can improve those symptoms. It can treat. transcranial magnetic stimulation. That is the other treatment. Magnetic stimulation of the left dorsal prefrontal cortex restores dysfunctional mood circuits. It indicated for the treatment resistant depression and medication intolerant. Advantage of transcranial magnetic stimulation include the advantage. It can be done outpatient, no anesthesia needed, minimum cognitive effect. Common side effects include headache and scalp discomfort. Ketamine need for rapid reduction in a suicidal ideation. Ketamine can be used if the patient is suicidal because it can reduce rapidly for the SI symptoms. Next, we want to talk about psychotherapy. Psychotherapy addresses the psychological mechanism maintenance symptoms. Medication modify the biological. Psychotherapy modify the cognition, behavior, emotional, relationship, and personal organization. So psychotherapy improves cognition, behavior, emotional, relationship, personality, organizations. So psychotherapy, cognitive behavior therapy is used for restore cognition lead to maladaptive. It restores the cognition that lead by the maladaptive emotional and behavior. The core intervention of cognitive behavior therapy is a cognitive restriction, behavior activation, exposure therapy, thought recourse. Cognitive behavior therapy is indicated for depression, general anxiety disorder, panic disorder, PTSD, OCDs, claustrophobia thinking, and avoidance. Didactic behavior therapy addresses the emotional dysfunction and impulsive. Dialectical behavior therapy addresses emotional dysregulation and impulses. The core modules include the mindfulness, this stress tolerance, emotional regulation, interpersonal effectiveness. Dialectic behavior therapy, or DBT, is indicated for borderline personality disorder, chronic suicidal ideation, self-harm, fear of abandonment, and recurrent self-harm. That's what it treats. Interpersonal therapy, or IBT, is focused on grief, role transition, relationship disturbance, and it's indicated for major depression disorder, PTSD, adjustment disorder, and it treats the symptoms following a divorce, bereavement, and occupational changes. Psychodynamic therapy, it is exposure, defensive mechanism, unconscious conflict, transferency, early attachment. It's useful in a personality disorder, complex trauma, chronic interpersonal dysfunction, repetitive relationship pattern rooted in a childhood experience. That's what it treats. Psychiatric rehabilitation. Psychiatric rehabilitation events after a symptom remission or many patients remain functional in bed. Recovery involves restoring the independency and community integration. That is what psychiatric rehabilitation does. Recovery involvement restoring the independency and community integration. And components include vocational rehabilitation, improves employment function. It enhances the interpersonal ability for social skill training, support housing to promote independent living, case management, a set of community treatment. So psychiatric rehabilitation include vocational rehabilitation to improve the employment, social skill training to improve relationship or interpersonal ability, support housing to promote independently, case management to coordinate care and services, a set of community treatment that promotes multidisciplinary intensive care for severe mental illness patients, medication role also that includes the long injection antipsychotic that improves treatment compliance and reduces relapse in a psychiatric in the schizophrenia patient, mood stabilizer, prevents recurrent episode in a bipolar disorder. Next, we wanted to talk about the constellation reliance psychiatric. Always rule out medical causes before assuming primary psychiatric illness, such as delirium. If the patient having delirium, you want to assess the causes. You want to assess if they are having an infection. You want to assess if they had a surgery. Is there a medication causing the delirium? Is there metabolic abnormality that will cause the delirium? Agitation in elderly, in hospitalized patient. Is a delirium until otherwise? So if they are confused, don't think they are having a dementia. They could be having a delirium, and that is medical emergency. Medication-induced symptoms. Steroid can cause mania and psychosis. Levodopa can cause hallucination. Interferon can cause depression. So there is a psychiatric conditions that caused by the medication that patient is taking. Maybe they are taking different medical condition, but it caused them mental illness. Medical illness with this psychiatric comorbidity include cancer. Cancer can cause depression. Stroke can cause mood disorder. Chronic pain can cause anxiety and depression. Level of care. Provider must continuously assess the safety and determine the least restrictive way and most appropriate treatment setting. So if the patient is stable, no immediate risk, they will be outpatient, they will be treated outpatient. Moderate impairment and safe home environment can be treated intensive outpatient. Severe symptoms without immediate danger can be partial hospitalization because you want to stabilize that severe symptoms. Immediate danger to safety and others, you want that is medical emergency, psychiatric emergency, so they have to be hospitalized. Suicidal intent or psychosis, mania, inability to care themselves, they have to be inpatient. Psychiatric, they have to be hospitalized. Also, you want to know why do the symptoms present? What caused the symptoms? Cognition or trauma or relationship or personal pathology. You have to ask that question, why? Why do these symptoms arise? Are they arise from cognition or trauma or relationship or personal pathology? Then you want to go to the next step and you want to identify the biology. You want to identify if this symptom is caused by neurotransmission system. Do these symptoms caused by serotonin or do this symptom is caused by dopamine? That's how you assist the patient. Are these serotonin-based symptoms, or dopamine caused symptoms, or gabapentin related symptoms, or glutamate? You want to know which neurotransmitter systems are involved. Next step will be knowing the severity of the symptoms. If they need for medication alone, or do they need a combined treatment, or do they need ACT, TMS, or ketamine? You want to assist their functional ability. Can the patient able to work? Can they maintain relationship? Can they live independently? You want to assist that. You want to also assist the safety. Is there a suicidal intent? Are they in a psychosis episode? Are they in a manic? Inability to care themselves? You want to assist safety assessment. That's what you want to check. You want to match the patient to the level of care that they need. Do they need outpatient? Do they need intensive outpatient? Do they need hospitalization? Do they need inpatient psychiatric? Do they need emergency care? Thank you for joining me today. Please subscribe. Join me next. Thank you.